Yeah, it's a real pleasure, as always, to present to the department on today the topic of value, which I think is a timely, interesting, and really wildly complex topic. So complex that I have called at least two friends to help sort of discuss this. So you heard, everyone knows Dr. Maggio, of course. I also invited Christian Howell, who is the Global Vice President for Value-Based Healthcare at Medtronic. Um, Certainly on a word of conflict, it's not typical to invite someone from the industry side, but I think when it comes to value and delivering the best outcomes for our patients using devices, which of course on the surgery side, we're very device heavy, thinking about high level partnerships with industry is necessary for doing that. And so while Medtronic certainly has an army of people still trying to sell you devices, I think the perspective Christian will bring to you today is the future. And you can decide for yourselves if you think that future of where industry may go is a positive or negative thing. So the agenda, I mentioned conflict, certainly worth highlighting that Christian does work for Medtronic, but will bring a perspective beyond simple sales. I have several conflicts that I've shared over the years through biodesign, but we won't be discussing any of that today, as today I'm really wearing my hat as someone who's worked for the hospital in the value analysis committees. So in terms of a couple of value fundamentals that I wanted to start the conversation with. I think this is something that everybody knows, but it's worth starting any talk about healthcare economics or value with, that healthcare is simply too expensive in the US. You can see from the top slide that the top chart, that we spend on average twice as much as any other developed country to deliver healthcare that's equivalent, in some cases, not even as good as other countries like Japan and Australia. Healthcare costs as a percentage of GDP continue to rise, and it's something that, of course, at the government level is highly concerning, and really overall for our economy is something that needs to be tackled. I don't think many people will argue with those high levels, so let's dig in a little bit deeper. In terms of defining value, this is where things get pretty complicated on a very fundamental level as surgeons and really altruistic level as physicians. Really what we value is quality and outcomes for our patients, essentially regardless of cost. As we shift to the perspective of the hospital, hospitals and payers really do play the role, as we know, of constraining those costs. And while they also seek better outcomes, they seek to do it at a lower cost. The equation gets slightly more complicated, of course, when we bring stakeholders. If ultimately the society, and if everybody could mute, I think there's somebody that's got a little background noise there. I'd appreciate that. Thank you. And then at a societal or government regulatory level, really the triple aim of medicine is better outcomes at lower cost with more access for the population. So that all sounds wonderful and achievable, but really when it comes down to value in the practice of delivering healthcare, it gets incredibly complex. It's measured in many different ways, and each stakeholder has a different equation and weighting for what matters to them when you try and deliver the triple aim of medicine. In terms of some trends that are probably also worth noting at the start of any value talk, one is we have certainly seen the rise of integrated payer providers. We can argue about what we as Stanford and Lucille Packard deliver in terms of healthcare compared to groups like Kaiser and Intermountain, but what you can't argue is that they do now have almost 50% of covered lives in California and growing. We've also seen a steady 10-year growth in accountable care organizations. They were originally piloted in the Bush administration in 2010 and expanded under the Affordable Care Act. And now 40 million lives approximately are covered by accountable care organizations that essentially are given a prepaid budget and then allowed to share in any savings they have beyond that per capita pricing for the patients. It's also worth noting that this may be accelerated by COVID, where we saw traditional fee-for-service institutions which Stanford is essentially at this point, take a real hit during the shutdown and shelter in place, whereas healthcare systems that had diversified their payment to accountable care organizations were able to maintain some level of fiscal health. There's a couple other trends that are worth noting. I think these are more pilot and probably not where things are going, but there has been several attempts by employers who tend to bear the, not tend to, who do bear the burden of healthcare costs in our economy to start choosing providers based on outcomes and cost. And there's also been several pilots of US-based payers sending patients abroad or essentially enabling medical tourism to be able to give them the option to have a hip replacement, for example, done in a country where it can be delivered with equivalent outcomes at a significantly lower cost. So putting all those things together, I think it's worth a reflection as an institution that we're significantly fee for service. We're one of the most expensive hospitals in the country. And in the case of Lucile Packard, we are heads and tails above every other children's hospital in terms of cost. And now, how can we go about potentially tackling that issue and putting ultimately financial health in the very long term in place? So I think this is where the three of us are going to take this from different angles. I'm going to talk a little bit about how the Value Analysis Committee has evolved over the last 10 years. That I've partnered with Paul and in conjunction with other leaders on the value committee side. Paul's going to then talk about really the next phase of how we can generate value through physician engagement. And then Christian's going to give us the perspective from industry on how medical devices and technologies could fundamentally be delivered in a different manner. So starting with the Value Analysis Committee, why have a committee? I think another important part of healthcare economics that people don't always understand is that hospitals have incredibly thin margins. The average hospital in 2016 had an operating margin or a contribution to margin as a nonprofit, but essentially a profit of 2.7%. That's incredibly low. Most service industries like law firms, et cetera, run margins of about 30%. So 2.7% is razor thin, and there's really no room for error. Clinician preference items, the big things we use like implants, like staplers, et cetera, are generally paid for in a capitated model where there's a facility fee to the hospital. That's what you get for delivering the care, and whatever you can fit into that, you either make a profit or you don't. And finally, really the health technologies and supplies are one of the biggest variable costs. And so that's really always a target for optimization. I like to use the following example to kind of make that more concrete from my friend and colleague, Dr. Shea, in pediatric orthopedics. So say, for example, you have a healthcare system that does have issues with long-term sustainability, and you want to generate $20 million of a downfall you had, say, for COVID. There's really three ways you could go about it. You could try to grow your revenue. But what equals $20 million for revenue? Well, that would require $800 million in new revenue at 2.7% margin. So you could cherry pick more profitable areas, but when it comes down to it, a margin of 2.7% really makes it very hard for revenue to make up for any shortfalls. You can always look at labor expenses, but that's a lot of positions and a lot of the people that would help us provide the best care possible. And then the natural target always becomes reducing supply costs or third-party spends. And strategically, there are more and more ways to do that, and we have more and more leverage to do that. How do we do it from, fundamentally from a value analysis committee standpoint? We really combine clinicians and experts who really decide, own, and give the clinical feedback for what devices and technologies are valuable and where we can accept devices and standardize. We have supply chain, which it allows us the tactical input of where things go and how to store it, which seems like a minor issue, but can lead to significant costs down the road if things are expiring on the shelves. And then ultimately we have operations who really use much more sophisticated data and analytics that are available to us in order to develop the best contract pricing and understand our benchmarks. So when we put all these things together, what we're trying to do is really to be a central organizational forum. We're trying to build a culture of value where we're engaging clinicians in all aspects of the hospital. We're trying to use process and be transparent, make it a partnership and a collaboration. We're not trying to dictate how medicine is practiced. We're trying not to be cumbersome, although it does require inputs from multiple groups that don't happen in an instant. And we try not to be just a products review committee, but really a group that looks overall at value in terms of the outcomes that devices deliver, the quality that they deliver, and measuring that against the cost that we incur. I like this sort of thinking in terms of the maturity stages of value analysis. I think when I started, we were having people hand us paper sheets, and we would just do our darndest to sort of guess if a device was worth it or not. And we would really just look at apples to apples costs. If we were going to bring in a new stapler, we'd look at what the old one cost. We'd ask a few people, and then we'd kind of make the best decision we could. And I think that's kind of really tactical. Occasionally we get some benchmarking costs. As we evolved the committee over the years, we really brought in the revenue side to understand every device we brought in, how it could affect revenue and profitability. We started to use real-time data and analytics from groups like Lumiere and from Vizient, which allow us to really have the kind of data and analytics you have as a consumer when you go to Amazon. And if someone asks for stapler X, we can immediately see, well, people who bought that also looked at this, and here's a comparison based on FDA data, clinical data, and other important factors. Ultimately, getting all the way up to clinically integrated, really that's the ultimate in terms of delivering devices and health technologies, where you get to ideas of risk sharing and interdisciplinary partnerships that I think I'm going to leave for Christian to speak about towards the end. So right now where we stand in terms of the current value committees at both Stanford and Packard is that we have a standardized combined intake form that Paul and I spent many years trying to make as simple as possible. I know people still don't love filling it out, but ultimately, to get devices through, it's really helpful to have a sense of how this device can improve the outcomes of your patients, improve productivity of the institution, improve patient satisfaction, provider satisfaction, or be part of a strategic initiative. And those are literally the criteria by which it's judged. And those are the criteria that we're transparent across with our industry partners as well, so that they know those are the things they have to hit to really be considered. If they're able to hit those marks and deliver a lower cost base, that's very attractive. Otherwise, there has to be justification for increases in costs. So finally, we've sort of taken that model, and we've used both those new product requests that physicians bring in to be opportunities for projects, and looking at areas where we can really decrease costs and standardize care. And we've also started doing more tactical looks at areas where there's opportunities. So the first areas, of course, just to look at high price items, things like spine implants and heart valves are always great opportunities. But we've also got the sophistication now to look at specific cases and contribution to margin, and even particularly spends by different classes of physicians to understand where these opportunities exist. And so taking sort of a three-phased approach to optimizing health technologies. The first is really to kind of attempt to standardize. So if there's multiple devices on the shelf, can we get down to a few vendors that provide the same amount of capabilities? By doing so, we can minimize the number of devices, we can minimize the inventory, and we can ultimately get better pricing. And spine is a great example of this, where we recently went from 19 vendors down to 5. That really cut the benchmark pricing on those 5 by a large amount, millions of dollars in savings. And it really improved our ability to do inventory management. So that was a huge win for the spine group. And then ultimately trying to do utilization management, where we're really looking at all the types of contracts that we're using, going to consignment and really optimizing other parts is where we ultimately want to get in terms of what the value committee can deliver to the institution. So I try to get through that quickly because I really want to have my partners share what they're up to. So I think that tactical level value committee, what we get in from the physicians, what we're able to do in terms of trying to get to standardization, reducing items, is one level of sophistication. But I think as I hand over to Paul, you're going to hear that what that needs to at least fuel it or take it to the next level is physician engagement. So Paul, do you want to share? I'm going to stop sharing my screen and hand over to you. And you're still on mute, Paul.
Okay, can you see my screen? Good, okay. All right, thanks, James. James had asked that I talk a little bit about some strategies we have at Stanford to engage physicians, and I wanted to highlight some of the work that we've actually done also in our department to do this. Just to reiterate this a little bit, this is the value equation. This is actually how we have defined it at Stanford, so it's one version of it, but essentially it's quality and service over cost, and we've included the value of our employees in it. But the point here is that I think as physicians, we've largely focused on the quality aspects of it, even the service to some degree. Historically, we have focused a little less on cost. But there are a lot of reasons why we should be involved in those conversations. And the first is that it's thought that 60 to 80% of the costs are really controlled through the decisions that we make as physicians, whether it's in the products that we use, in the operating for examples, or the lab tests that we order, and the treatments that we prescribe. As physicians, we also have firsthand knowledge, I think, of the clinical workflows. And many of us have seen this historically. Sometimes the hospital or administration may make a decision that might not make the most sense from a clinical perspective. And I think there's value in having the physicians engaged there. I hear somebody, I don't know if somebody needs to mute. Also, physicians are important in really understanding the relevance, understanding what is evidence-based and the outcomes that apply. And then, of course, in leading change, it's important to have physicians there to make that happen. So lots of reasons why physicians really do need to be involved in this. There are some challenges. The first is that as physicians, many of us view our responsibilities as exclusively providing the best care possible. We want the best care for our patients, and cost reductions are generally considered to be outside our purview. I'll give you an example of this, something that's happening right now this month, actually. There is an initiative now to provide cost transparency around pharmaceuticals. So now when you go into Epic and you look, you will see for the medications that you order, the costs on a daily basis. That was considered somewhat controversial. I think some are concerned, it may not be unreasonable, but that physicians may make a decision based on the cost. Maybe they wouldn't do what's best for the patient. I actually do not think that's the case. And I would argue we should have access to that information. It should be transparent. It's important to just being good stewards of our healthcare resources. So that's just one example. And I know, James, I think you've done some of this at LPCH as well. I know that we've provided some transparency around costs in terms of the products that we use in the operating room. So I think it's important that physicians have access to this information. Some other barriers, many of us are clinically very busy. We don't really have time to focus on supporting the organization and cost reduction initiatives. And lastly, there's legal barriers here. So there is anti-kickback legislation in place, which really prevents organizations from directly incentivizing physicians, directly compensating physicians for essentially limiting costs or decreasing resources. So it's interesting when you actually look at healthcare systems, you can have shared savings programs with CMS at a much higher level, at an institutional level. But when it comes down directly to the physicians, there's legal barriers to directly incentivizing them to participate in cost savings. So something that we've come up with at Stanford is physician-directed reinvestment. And essentially that's an agreement with SHC where physician-led initiatives to reduce costs. So again, these programs are really focused on the cost aspect for the most part of that value equation. 50% of it, for the most part, or half of it, will go back to the department. And it can't go back to directly compensate the physicians, but it can be used for capital purchase. It can be used for education. It can be used for research. So for example, hiring that statistician or a project manager. So that's the way we've set it up to provide that incentive to engage. I did just want to provide you with a high-level overview of the program. Again, its purpose is really about aligning SHC and the School of Medicine, because that's not always the case, and that's through sharing the cost savings. And it's based on the first year, and it's based on what is realized. So it's actual savings. And based on that first year, half of it will go back to the department and ultimately directed by those physicians that lead those initiatives. After the first 2 years, this is where we were. And the important takeaway point, I think, from this slide is that we were able to engage just about every department in the end. I think when we started this program, most people thought, oh, well, it's neurosurgery and orthopedic surgery where they really do use expensive implants that would benefit the most. But it actually was across the institution. Some were surprising. I would argue, pathology, for example, came up with many different innovative ways to reduce costs, improve turnaround times, decrease stays in the ED through changing the way they do tests. So innovative as well. And the Department of Medicine, I think, continues even today to be the department with the largest savings. This was just an overview of what we accomplished just about at the 2-year mark. We had over $27 million in savings for the organization. 38 physicians were engaged. As I said, many departments. About half the initiatives, or slightly less than half, were around just what James pointed out, the products that we use, what we call physician preference items, or PPIs. But the majority around clinical improvement opportunities. How can we improve the way we deliver care on the inpatient side? I'll just show you a couple of examples. We do use Vizient data to help us. And what I'm showing you there is that on the bottom left is that's a PCI. That refers to a price competitive index. So what that shows us is how we compare in terms of pricing for the products that we use to other organizations that participate with Vizient. So in the middle there, PCI before initiative, you can see, for example, shoulders. That suggests that 89% of the organizations that use this product get better pricing, receive better pricing than we do at Stanford. And then you can see after the initiatives that we're able to drive those numbers down. In fact, we would argue, and I don't know if Amanda Chowler, who's our VP of Supply Chain, is in this meeting, but I think we all agree that at Stanford, we probably should be top quartile, right? Based on our reputation and outcomes, we should be doing better. So this program has actually helped quite a bit in getting us there. Some more work to be done. And that last portion of the slide was really to highlight that we do look at balancing measures, other measures that impact outcomes. One, to make sure that we don't negatively impact other areas. But I would argue for the most part, we have seen improvement in outcomes as well, whether it's decreasing the turnaround time, improving wastage, and so on. So not only is it focused on cost, which is what we can measure and what the program is really centered upon, it really has improved many outcomes. Something else that I'm really interested in actually is the incentives and how we apply incentives to engage people. And there's one thing that I really want to point out here. And by the way, so we've studied this a little bit. So we partnered with Steve Ash's team. Steve Ash is an implementation scientist, to look at this program and see what the return on investment is, and then how is it doing in terms of engaging physicians. And something that I have always believed for this program is that it's important that we have the extrinsic motivator, which is simply that, there are funds that will go across to the department, but it also intrinsically motivates people, meaning that there's some sense of autonomy here. This is not a top-down approach. This is physicians bringing ideas forward that they want to take on and lead. There's a sense of accomplishment, mastery, and so on. So I think that really is valuable for the program, because the intrinsic motivators are much more powerful. And if you look at some of the comments, some are from department chairs. I love that. So he's got 15 years of pent-up ideas on how to improve the operation. So he's going through them. A lot of these initiatives were things that were on not on anybody's radar on the SHC side. These were ideas that physicians that know where these opportunities are, bringing them forward. So really important for the program's success. I did want to highlight some of the work that's been done here. We had a project on level of care, and I know Ron Dahlman led parts of that, as well as David Spain in our department. Jason Lee did some work on balloon catheters in vascular surgery. Arash Momeni and Mary Hong worked on surgical mesh. Again, and many of us probably experienced some of this, consolidating the products that we use. When you have lots of vendors, you really cannot negotiate very well. So it's about, can we consolidate, can we standardize on some of the products that we use? Rib fracture pathway is one that's a very good one. I think it's a multidisciplinary initiative, and it's now beginning to look at the continuum of care and how we manage these patients that come in with rib fractures. So Lisa Knowlton and Osama Nassar led this. From the residents, so there's a residents high value care challenge where they can bring forward ideas, and if they're accepted, I think they're recognized. Josh Jaramillo brought this one forward, and it's something that we have implemented now, so a really good initiative. And there's some others that we're looking at now going forward. I know Mark Melcher's presenting one on transportation improving opportunities there. And Kim Stone and Rahim Nazarali are working on one, at least they're proposing one on biologic implants, which will benefit the department. So some ideas. I just put this on the right, the screen shot. If you were to type in CSRP on the portal, it would take you here. And here you can see how to apply. You can see all of the active initiatives and those that had been successful in the past, and anything else you need to know about the program. So something to think about if you have ideas. Now, there's one other program I wanted to discuss, and that's something I lead on the ambulatory side, and it's ValueBased Care. It's a new program that started this year. It takes it from a slightly different perspective. So when you look at the way we manage costs, the CSRP program focuses on costs on the inpatient side. That really does benefit the organization, benefit Stanford. Not so much, at least initially, that would be perceived by the patients or the payers for that matter. This program is focused on the payers, for example, our own insurance product. So it changes things slightly. This is looking really at utilization. The things that we order, because on the ambulatory side, there we, for the most part, are reimbursed for the things that we do. So I would argue this program looks at what's best for the patient, in principle, even if it potentially decreases revenue. Again, it plays out in terms of coordination. So it's important, for example, in the workup of a malignancy, for example, how we coordinate care, what tests are ordered. Is there redundancy there? Is there a lot of waste, things that we don't need to order, and so on. From the perspective of the payer, the measure that we use is the PMPM. That's per member per month. So that's how you would look at it from the insurance. How much does each member cost on average per month? And of course, this was focused in the ambulatory space. So I just want to show you a little bit about that. So SHC Alliance is our insurance product. Many of us probably participate in this program. You can see that trend initially increasing over time. And the intent of this program was to bend that curve. So our target was this $952 essentially dollars per month. So that was the outcome we were all focused on and trying to achieve, again, generally by coordinating care on the ambulatory side. Some of the initiatives that we looked at, we broke them down into sprints and marathons. Sprints were really the big initiatives that were multidisciplinary that we knew we had to get done. Big opportunities there. For example, cardiac imaging is a big one. How do we work these patients up? There's often a lot of redundancy. I think for surgeons, we probably see this as well in your area, right? You may see that a workup has been done on the ambulatory side. Maybe some of it was unnecessary. Maybe they should have sent them to you earlier and so on, or maybe they should not have sent them to you at all. They didn't need to. So those are the type of opportunities we're looking for. Behavioral health and so on. And then each department that didn't participate in a sprint took on what we refer to as marathons. These are, for most part, smaller initiative, maybe less multidisciplinary. Surgery is here towards the bottom there, and Yulia Zak is our VBC lead, leads this initiative that was focused on the preoperative workup of breast cancer. So again, it was a multidisciplinary effort that Yulia led, but with oncology, with primary care, with radiology, and so on, to streamline the way we provide care for patients. And not only is it improving the PMPM, but probably improves patient experience as well, right? There's less waste, less redundancy in the things that they're doing. As I said, general surgery she is our lead. We'll be taking a new project this year. We did meet our target for this calendar year for 2020 for this program. I think a lot of good work was done, but to be honest with you, I think COVID had a major impact. If you look at healthcares across the country, nationally, they've all seen a decrease in this measure. I'm talking about PMPM. It's just decreased utilization, right? People are using healthcare less now, fearful of the COVID pandemic. That said, we're continuing to build on this program. We're now focusing more on multidisciplinary efforts, and I think this may get into a little bit of what we're going to talk about in a little bit about how do we integrate care, because now we are starting to focus on really the continuum of care. We've engaged the inpatient side as well to really understand how does that impact what's going on in the ambulatory space. And then there's further efforts by the organization here at how do we support this and sustain a lot of this work. So I think that's my last slide, just reviewing the two programs. And I think, James, are we leaving questions until the end? If so, then I'll just turn it over.
Yeah, if you wouldn't mind just turning over. Thank you, Paul. That's a really wonderful overview, and really appreciate your leadership. And in fact, kind of a breaking news is that we are now approved to do a pilot of cost savings reinvestment at Packard as well, based on the success that Paul's shown at SHC. So really exciting that we can now leverage the entire enterprise to be able to even drive further projects, and we'll take the lead on more, peds first and peds specific projects at the Children's Hospital. So Christian, are you able to take over the screen there? It looks like we can see your slides.
Can you see my slides? I unfortunately can't, so I am trying to pick them up.
We can see them, but if you want me to flip through them, I'm happy to do it.
If you do that might make it easier.
Hey, why don't you stop screen sharing and I'll take over? Thanks.
And as James is bringing that up, I want to thank Dr. Wall and Dr. Maggio and the team at Stanford. I think, I appreciate that this is relatively unique, having a member of industry speak at a grand rounds, but I do think it talks directly to a bit of the challenge of value-based healthcare, which is because of the complexity that is required in identifying appropriate cohorts of patients, measuring outcomes, measuring costs, it's going to really require a much closer collaboration than I think that we've seen in the past. And so I think this type of dynamic and this type of dialogue is really critically important. One of the questions that I get asked most often is, why would an organization like Medtronic want to wade into value-based healthcare? The organization can do very well in a fee-for-volume model. But what we really feel like, and I think that this would be true across our industry partners, is we really need to see three things for us to be able to do it. The first one is value-based healthcare needs to align to the mission of the organization. Medtronic was founded in 1949. We had a CEO recently by the name of Omar Ishrak, who really took some time studying our mission and its various tenets. And his takeaway was that if you boil down what Medtronic's trying to achieve, is that we're an innovations company that's trying to create solutions that improve outcomes. And those outcomes, whether they're clinical or economic, we have a responsibility as an organization to do that. And that aligns directly to what Dr. Maggio shared from Mike Porter and the definition of value-based healthcare. So the edict was given as an organization that we were driven to value-based healthcare. James, you can go to the next slide. The next piece of that was, is it a market demand? And so as we went around the world and talked to our various customers, we heard very clearly these sort of first two things. That one, that the expectation from Medtronic was to continue to create innovations that improve clinical outcomes. But the second expectation was that we work with health systems to optimize cost and efficiency. And what's really interesting about this is we recently did a brand survey, and so I think the rest of the industry would find this as well. The third on this, when we talked to health system leaders, was the expectation that Medtronic would serve as a partner in the exchange and sharing of data to drive value. So that, if you think about the three things that were driven as the most important priorities from the voice of our customers, it was give us better clinical outcomes, improve our costs, and help us understand data to drive value. So very clearly that we were sort of meeting the needs of the customer. And then, finally, I think what's critically important is that the organizations, the industry embeds it into their strategies. So we had a very public investor day on Wednesday of last week, and one of the things we came out very clearly with was, look, value-based healthcare has got to be a part of our strategy. So what needs to change is if you look at the left side of your screen, this is the world that industry lives in currently, right? So we drive our revenues based on the development of technologies, and we promise to change an outcome. Now that promise is credible, and we go through a process of technology development, we go through a process of clinical trials, we then build a cadre of sales professionals to bring those out to providers and inform them and educate them on that data, the credibility of that evidence. But again, still the revenue is driven simply by the promise of the delivery of the outcome. If we're going to change the model and move our revenues to only being compensated on the delivery of an outcome, well, now that ecosystem expands pretty dramatically. So we still have all of the precursors. We have the responsibility of the development of technology and the validation of that technology through trials and the publication of that through journal. But now we need to start to build a new array of stakeholders. And one, I spend as much time talking to organizations about artificial intelligence and machine learning so we can understand how to extract the data from our devices so that we can clearly identify the cohort for our patients and clearly understand the outcomes that we can impact. We have to understand some of the patient and data management services. We spend a great deal of time with Epic. And we have to understand, we work with organizations like ISHOM and the National Quality Forum to understand not only outcome measure sets, but how outcome measure sets are derived and how they can be informed. And then lastly, I think industry needs to get much smarter on the care pathway. I think Dr. Maggio referenced this, which is oftentimes our area of focus has simply been on the application of our technology in a particular instance in surgery. But if we're going to be taking accountability and financial responsibility for the delivery of outcome, now we need to widen that aperture a little bit and understand the care pathway. And so what it's really required is for us to create a whole new array of partnerships. And these partnerships are comprehensive and robust. They're not commercially focused, but they're really about understanding environments and drivers that we've not previously had a fluency in. James, you can go to the next slide. So Medtronic started on and I think this is in keeping with what a lot of my fellow industry partners would say, is we are kind of taking a crawl, walk, run approach to this. The crawl was to try to understand what the role of a medical device company could be. And what's interesting is if you think about these sort of three key tenets, that one, the outcomes need to be clear and measurable, the cohort has to be very specific, and we have to understand the complexity of a care path. Medical technologies, almost more so than pharmaceutical companies, are better positioned or to be able to impact value-based healthcare because our technologies are engineered. And oftentimes the approval process for our technologies, the ability to get feedback on how a technology is performing, the ability to then re-engineer that technology and bring it out to market, the development life cycle of a med device versus a drug makes the pursuit of these things of clear outcome definition and clear cohort definition a little easier. But if we can do these things, if we can understand, how to specifically measure an outcome, how to specifically identify a cohort of patients and the appropriate utilization of a technology, and then understand how that technology is embedded within a care pathway, we believe we can start to create, and what we learned was that we can start to create kind of innovative business models where we started to take some risk in the outcomes. So that got us to the walk, and James, maybe you can go to the next slide. And so what we did was we sort of interrogated our portfolio and found technologies that directly correlated to an outcome. And we started to create business models around this. And I put this slide up not as a recognition of the work that Medtronic has done, but almost more so of a criticism. Because what we heard when we started taking these to market and started talking to health systems was these business models are interesting, but they're not impactful because they're not necessarily aligned to the cohorts of patients and the disease states and conditions that are the biggest influencer to some of the cost drivers that the health system is seeing that both Dr. Wall and Dr. Maggio spoke to. So I think that this was a first kind of foray in understanding, could we start to change the business culture But what we found is to be able to make this type of value-based healthcare work really impactful, we had to work much more closely with health systems. And so we started, and James, you can go to the next slide. We started trying to identify the right sort of partner model for this. You can look at the profile on the left of the health systems that we were looking for. One of the CEOs, the CEO of Lehigh Valley, likes to say, if you look at the fourth one down, that there is a need for a health system to have a little VBHC PTSD, to just understand how difficult it is for a health system in independence to be able to go and try to do value-based healthcare models or value models, and that they will most likely have an environment that it's more it's more attuned to, more accepting of outside partners. So we started creating a very narrow network of partners where we could bring data scientists, analysts, change management experts, healthcare economics into these health systems to really understand how we could pursue value. And you can see on the right some of our key learnings. I would say the middle two, I think, are the most important. The last one is probably not surprising. The first one is partnership oftentimes is talked about as too much of an art and not as much of a science. And what we learned was if you're going to be a partner with a healthcare system, or if a healthcare system is going to partner with industry, that there needs to be very robust project management, legal alignment, data alignment. You need to create a very highly structured ecosystem. The second is we created we followed sort of a DMAIC process for a clinical intervention, and I'll walk through an example of that. But there needs to be a very clearly defined process that can be socialized with the clinical staff so that they understand when you're going to a new disease state or condition, what's the process that's going to be followed. And then lastly, we can do all kinds of work that's really interesting, that talks about getting the right technology to the right patient at the right time. But if we don't align a payer to incentivize that drive for value, it becomes interesting, but not meaningful to the health system. So I thought I'd show, James, you want to go to the next slide? I thought I'd show just an example of how we pursued this in one of the service lines at the Lehigh Valley Health Network. The first thing that we did was their chair of anesthesiology came forward and said, I have a cohort of patients that is receiving IV opioids either for post-surgically or for a medical condition that is at risk for respiratory failure. I would like to figure out a way to provide an intervention that I think could help mitigate some of those adverse events. We began to look at our clinical trial data and understood that if we could apply a combination of capnography and pulse oximetry and monitoring, that we could reduce those adverse events, rescue drug administrations, ICU transfers, code blues, and that we could ultimately put a financial metric around that. We then began to measure the current state of the application of those technologies in this particular cohort. And what we were actually able to find is that at times we could stratify the cohort more deeply, looking at patients with elevated BMI or sleep apnea. And so what we found is that there were times at Lehigh where the intervention was being appropriately used. There was times when the intervention was being underutilized, and there were areas of the health system where it was being overutilized. So what it allowed us to do by measuring that current state was to really identify what's the appropriate cohort for that particular intervention. We then were able to develop business models around this that allowed us to take accountability for a reduction in the adverse events. And then began the very hard work, which is, if you look at these first three, it is our belief that we can digitize this type of query and measurement, that we can begin to build automated query sets to identify cohorts, and we can share those. Not always will the solution be a Medtronic solution. Oftentimes we might find that in this cohort, there is another technology that either delivers a better clinical outcome or it delivers a better cost, but it at least allows us to use our clinical data to begin to identify that group. But the hard work began in kind of 4 through 8, which was the build an epic, automated decision support, clinical best practice alerts, training of the nursing staff, automating the pathway into Epic, building the compliance mechanisms to make sure that when that cohort was identified in Epic in the care pathway, that alerts were notified of the suggestion for the utilization, embedding the business model so that if there was an adverse event, we captured it to make sure that we could keep track and determine. We didn't want to make it arduous for the remuneration of the risk share model. And then we went live, and James, you can go to the next slide. And what you saw when we went live on this was, one, we went live in 2019, a very dramatic increase in the adoption of the technology into this particular cohort that we were tracking here. Now, what did we see is correspondingly, as we saw, a lower rate of adverse events. They did not see any code blues. We did not see any mortality associated with this particular cohort, and we saw a length of stay reduction. But what we did in our partnership was we started to create KPIs for both organizations that we wanted to measure. We wanted to make sure that we were reducing variation in the care pathway, and that we were seeing better outcomes, that there was a contribution margin impact, as James identified earlier, and that the physicians and the clinical staff felt like this was additive to the care of patients. We also wanted to make sure that it was a sustainable business model. That did it impact revenue for Medtronic? Were we able to restructure our SG&A, meaning we didn't use any sales reps at Lehigh Valley. So we were able to change our commercial model pretty dramatically by doing it this way, which then in turn, we could do margin offset and with the health system. And then did it give a different market position for Medtronic? So I think this type of thinking, this type of work is what we're going to see. This more front end work is what we're going to see more of in the industry space. James, you can go on the next slide. So if the first work was interesting and not meaningful, this work was much more meaningful, but really difficult to scale. Because what we found is, certainly in those first three stages, the amount of disparate data sets that we were taking in that were required both from a supply side to understand from our clinical trial cohort, outcome, cost, and then from the clinical side, how to be able to interrogate and find those, it became really difficult. And we had to start thinking about a new model. And so, James, if you want to go we can go on kind of the last slide here. The thing that we learned is we had to think about this much more like an Uber or an Amazon. We had to think about this in a platform model. It had to be a completely objective platform. It had to be an open platform that couldn't just be Medtronic technologies. It has to be an array of technologies that are available within the supply chain and materials group at a health system. We had to take data from payers. We had to take data from the industry. We had to take data from the health system and begin to sort of architect this matching and coordination. So one, collect the data, normalize the data, begin to facilitate matches at the health system that we can get the best possible outcome for the lowest possible cost, regardless of vendor, and then begin to work that coordination on the adoption of the technology so that we could start to really measure impact to value. So as we think about how the dynamic changes moving forward between industry and the health system, I believe this level of data sharing and complexity is going to become much more standard than what we have seen in the past, which is sales professional armed with clinical data to go influence an end user with no line of sight or accountability to the impact to the total cost of care of that intervention. So, James, I'll stop there. I certainly want to leave time for questions, but that at least is how Medtronic, and I think from talking to my counterparts and colleagues in industry, we're beginning to think about value-based healthcare.